Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 30, Epicenter of the Pandemic, Driving Transformation at Northwell. It will be presented by Chris Hutchins, Vice President, Chief Data and Analytics Officer, Northwell Health. Enjoy the session.
I'm really excited to be here today to be able to share with you our experiences as we were learning how to navigate the pandemic. And we'll talk about some of the things that we did that really positioned us to be able to support the health system and, more importantly, the population that we're here to take care of. So we'll hit a little bit about our background so you understand how the organization is organized. We'll talk about some of the specific things that we did that, again, positioned us to enable the level of support that was required to keep the operations moving efficiently and to be able to take care of the patients as they were coming through our doors, and obviously very, very scared. Then we'll wrap up with some key learnings and recommendations that I think that you may find valuable as you're navigating not only in the current situation, but in the future as well. We'll talk about a number of strategies. In particular, I'll spend some time to talk about how we use data marts to enable and drive self-service analytics to reduce the burden on the central team that was trying to support the COVID outbreak, at the same time being able to enable the business to continue in critical areas that it needed to be able to do just to keep the lights on. Then we'll talk about why it's so important to have a flexible model for a cohort definition. In this particular instance, it was a rapidly changing definition that we were dealing with, even in the sense of how we were defining an ICU bed. And then lastly, we'll talk about the importance of aligning key resources to enable rapid response as you're navigating in a crisis such as the pandemic. For some background, Northwell Health is located in the New York City, Long Island area. We're the largest private employer in the state of New York with 72,000 employees strong. We have a service area of over 11 million people. We also have a robust research institute here, the Feinstein Institute for Medical Research. We also have a medical and nursing school that we're graduating a fresh class every year. In fact, this year's class graduated early and very quickly moved into our hospitals to begin to support our population as we were dealing with the crisis. New York has had the highest number of cases in the nation. What you may not know is that Northwell Health was the hardest hit healthcare system. We treated and released over 17,000 patients and counting. At the height of the pandemic, we were having to create 200 additional beds on a daily basis and adding new healthcare professionals from across the country to help us take care of the influx of patients that were coming to see us. Now let's talk about some of the keys to the success that we've been able to have. One of the things I found early on is the organization had the foresight to organize and co-locate technical and clinical staff in the analytics groups. Why this is important is a technologist doesn't necessarily know which version of a diagnosis code is the appropriate one for the business case that's being presented in front of them, because it may live in several tables and locations throughout the data model depending on the EMR that we're talking about. So having the clinical individuals there with the expertise that understand the clinical workflow and the user interface workflows inside of the specific platforms really helps to streamline the gathering of requirement documentation, and as well, it also shortens the cycle time to deliver appropriate data structure and enable effective analytics. The next thing we did that was really significantly important and beneficial was leveraging organizational structure and technology to facilitate collaboration and coordination of analytics across the business units and service lines. One of the ways we did this is by establishing an analytics resource center, which is really designed to facilitate the coordination and collaboration of various analytic groups across the organization. And the next thing I think is probably a common thing that most of you are connected to in some way, whether people are talking to you to get an understanding of your priorities, or you're doing the same thing in your organization to help understand what are the organizational goals and objectives, and then aligning your roadmap for your analytic experts to support those goals and objectives. The next two items were significant for us in that we needed to stand up an enterprise data warehouse, and at the same time, the business had legitimate, ongoing, growing needs to establish more advanced analytic capabilities in multiple verticals inside of the health system. So in order to do that, we made the decision to also stand up a self-service analytics environment to facilitate that while we're building the foundation for the data warehouse. We're also enabling all of those verticals to make advancements at the same time. So the objective of the data warehouse was relatively simple. We really wanted to create a single view of patients across the continuum of care across the enterprise. In our particular case, this was challenging because we have multiple EMRs inside of the health system. We have one ambulatory and one enterprise inpatient, but then we have a number of legacy platforms throughout the provider network that make it very, very challenging for us to get to the common single view. So an enterprise data warehouse was really important for us to begin moving towards achieving that goal. Then, as I referenced earlier, to enable self-service analytics, we really need to curate and organize data structures and data marts to allow folks to have advanced capabilities within their verticals, but not force them to really fish through all the hundreds of thousands and millions of records with all kinds of different attributes that really didn't have anything to do with their particular vertical. So the finance folks, for example, really didn't want to be digging into our diabetes data marts necessarily. That doesn't mean they can't, but it certainly didn't answer the financial questions that were top of mind for them. So we organized in a way that allowed us to do that. More significantly, in our case, we decided to put some technology in place to help us streamline the data movement and the processing of the data. On a daily basis, we're moving at roughly about 4.7 billion updates across our various environments, primarily with just the clinical records. If we add the other data sources and data streams in the organization, you see a very different number. So we had to also have a scalable framework in order to enable not only the retrospective analytics, but also real-time operational dashboards. And just at a high level, this is a slide that I like to use to help our executives understand how we're processing data. This is akin to maybe a data factory, I would say. If you look at the standardization gears, there's some technology that we use in there to map and standardize the data to common concepts such as RX norms, SNOMED, ICD-10. And again, as we have data coming from multiple source systems, mapping and processing is a really critical element to be able to translate things into the data structures you see inside of this EDW model, where we have patients, diagnosis, provider, et cetera. Each of those are data structures that we attach a number of attributes, everything that's really pertinent and relevant to know about the patient or the provider, et cetera, to make it really easy to incorporate those data domains inside of the new data marts that are really targeted for very specific purposes. As you can see, quality metrics, those can be regulatory or contract-based. The ED service line, we have a very specific model to be able to support them in real time. So they're really understanding what's happening in each of our 23 plus ERs throughout the health system and understand what the wait times are and be really effective at managing capacity, managing load balancing, and managing staffing. And as you can see in this illustration, data analysis and visualization can occur in either area here. We can go directly against those sources, or we can go against the data marts that have been well curated to make it simple or easier for the various verticals to inquire about the areas that they're concerned with. And some of the keys to success. Identifying organizational priorities for access to build subject-focused data marts was a really big area of focus for us, and I'll tell you a little bit about that shortly. Again, limiting the burden of access is a whole nother set of challenges. As you know, when you're in a health system and you're dealing with PHI, you have to be very careful around controlling access and only providing minimum necessary access for folks to be able to do their jobs effectively. So as a rule, what we've done inside of our environment is we try to inherit the permissions native to the source systems and only allow the permissions that are granted in the EMR source systems inside of the data warehouse as well, to keep it really simple from an access provisioning perspective, so that our team's not having to interpret whether access is appropriate or not, just from a data management or an analytics perspective. And then designing these enterprise data marts to be extensible and scalable to enable broad inquisition that supports essential business functions. What I mean by that is that to manage a diabetic population, you need a lot of the same common core data elements that are required in a number of other areas, whether it be another specialty or even in patient accounts and accounts receivable management. But then there are actually some specific attributes that are very, very relevant, it's more important for an endocrinologist to be able to see than perhaps a surgeon who's maybe focused on hand surgery, for example. Doesn't mean it's not relevant, but it's easier for them to get to the things very quickly and easily that are really relevant to their area of study. And this is just a high-level example of some of the data marts that we have in place. As you can see, that it's very logical. Diabetes, I've already mentioned. Surgery is a very important area. We bring together data both from the surgical systems, the inpatient EMRs, and our ambulatory EMRs to provide a holistic view of the patients that are either candidates for surgery or have been hospitalized for surgical procedures. Additionally, we have one for pharmacy, which I'll highlight in a moment. Also mentioned real-time for emergency services. We also have that for our hospitals as well, and this became really important for us during the height of the pandemic. Our operations centers had to have very real-time information in terms of our admission rates, our discharge rates, and our capacity, the number of beds available, a number of other factors. And I've got some visualizations I'm happy to show you as we progress through this presentation today. Then we have what we call our healthcare analytics reference data module, which is really all of the things that we use for standardization. We use the standard reference tools that are published and publicly available, but we load them into a module that's made available to all the consumers of our data and analytics capabilities inside of the enterprise platforms. This is an example of what I was referring to when I was talking about defining really robust subject area marks that are extensible and scalable. This is output from a data mart we built for our corporate pharmacy division. What you're seeing here is prescribing trends for ambulatory, but we can put a different lens on this to serve other purposes, such as the opioid crisis. We were tasked very, very quickly to stand up a way for people to be able to monitor our progress in reducing the rate of opioid prescriptions and consumption. It was very easy for us to put a new lens on the same data set that we curated to meet a broad range of inquiries. Similarly, we did this in the quality space. What you're seeing is an example built on a patient registry that we set up, where every time a patient walks through one of our facilities, we start calculating all of these measures, whether it's HEDIS measures or risk scores, all these types of things that are really pertinent to understanding and managing a patient while they're admitted in the hospital. We can put different lenses on this for different purposes. We have gaps in care programs and things of that nature that all feed off of this same data set. And it's also flexible, and it allows us to join this with other data sources. Another great example, what you're seeing here is based on same data structure and same principle in our emergency services, but one is retrospective, so you can see trend over time, but the other is near real time. And why that's important is you want to understand if what you're seeing currently is an anomaly or if it's a pattern that we need to address by making adjustments in our workflows or staffing or a number of other scenarios that this type of an analytic output will highlight for you. And one of the more exciting parts is when you organize your data marts by data domains and you structure them well, it gives you the capability to begin to integrate different views and different data types to create a real dashboard or scorecard. And this is one we did for one of our senior physicians to really enable the monitoring of a physician's performance as an individual to see how they're performing in a number of different quadrants, as you can see here. This is only possible if you can build really efficient, organized data structures that are well curated and designed specifically to be efficient and run at high speeds. All of these things were precursors and foundational elements that enabled us to begin to understand and react and adapt to the pandemic when it began to impact us here at Northwell Health. So in response to the health crisis, it became clear that the use of data to support and enable preparation and response activities was going to be critical to us, and it absolutely proved to be such. So let me talk about some of the key things that we had to do that I think you should be thinking about as you're entering into any crisis situation. when you don't understand necessarily the evolution of the definition of the disease state or the particular situation that you're facing, it's really important to open up lines of communication and keep them open and have consistent cadences to have the conversations you need to have. When we started this thing, there was no ICD-10 code for us to be looking for. So we're looking for all the symptoms, there's flu-like symptoms, respiratory in nature, or whatnot, to be able to build a cohort, to be able to start monitoring patients that we thought had the potential to be COVID positive. And at that moment, we also didn't have testing capability, if you recall. So building this with some flexibility was a really important thing for us to do. But more important was the communication between all the various stakeholders and consumers of data, both from an operations center perspective, but also for research, because we needed to enable researchers to begin to work immediately on this because of the nature of the disease and the rapid spread of it. We needed to make sure that we were making the information available for public health purposes as soon as we possibly could. And to really spend some time focusing on increasing coordination. The health system has many groups that are focused in different disciplines doing analytics, but we wanted to make sure is that we were communicating, sharing information, and we were collaborating effectively so that we weren't all trying to tackle the same problems, but rather we're each tackling a different component, ensuring that we're covering the broadest spectrum of things that we possibly could to support the organization through the pandemic. And this coordination was really critical between frontline staff, database teams, technical teams, data scientists, web developers. All of these different disciplines were needed to be able to come together to help the health system to move forward through this amazing, amazing time. I touched on cohort identification, and this kind of elaborates a little bit on it. But one of the things we had to do is very quickly identify a team made up of various different expertises and experiences to have regular touch points to understand what's happening over the next 3 to 5 days. What should we be anticipating from a surge perspective? How do we load balance? How many beds should we be expecting to have? As I mentioned in an earlier slide, we were over 200 beds a day being added in our hospitals above our capacity. On one day, the governor of New York actually gave us a challenge to increase capacity by at least 50%. Every health system across the state. We had to scramble. We were actually turning conference rooms into ICUs. We were converting convention centers and conference rooms. Inpatient wards were COVID positive only that were previously used for a broad set of purposes. ICU beds were changing by the day. We thought we knew how to define those, but that changed because we started to have to create new beds. So we were having to designate some as ICU beds. Some were COVID, where we had our COVID patients going to. But at the beginning of this, we also had normal business cases, clinical cases that were coming through our health system as well. And until we were able to get some of those folks in a better state of health to be able to be discharged, we had to manage and juggle that very, very carefully so that we weren't having COVID or potentially COVID positive patients in the same proximity to patients who we knew for sure didn't have any signs or symptoms. And again, the nature of the disease, again, we were learning on it, and we're still learning today. It's definitely a very different situation when you're trying to find a way to codify information that's not been coded before. So this was a really important aspect of what we had to do is we built a model that allowed us to flex. So we could look at chief complaints at time of the patients presenting, or we could look at diagnosis codes, but we had to have the flexibility to look at it both ways to be able to adapt and adjust on the fly. And then the key thing that really helped us is we identified the need to have 3 different patient registries, one for inpatient, which had to be near real time, one focused on the ambulatory network specifically, that we could actually begin to understand from a testing perspective as patients were starting to be tested, where the patients were coming from and what we needed to do to manage the practices, as some practices were needing to be shut down and some of the staffing from those practices was being redirected into the hospitals to take care of patients at that time. And then research needed to actually have a combined perspective looking at both inpatient and ambulatory, but also looking at our lab data sets that were being sourced from our core lab. And our core lab actually serves and supports a service area even outside of the patients who come into our health system to receive their care directly. Some key strategies I think were really helpful and important. We recognized the need to make some adjustments very quickly to be able to ensure that we were refocusing on the priorities that were most important at a particular point in time. So there are a number of projects that we had to hit the pause button on to make sure that we were really bringing the right level of focus and intensity to help the organization understand and manage the patients that were coming through our doors and be able to anticipate what the needs were on an hourly, daily, weekly, and bi-weekly basis, but more daily in the early stages. We designed and deployed an inpatient data mart using that registry, including all their medical history. We had to coordinate with the research team to design and deploy that data mart. The needs that they had were very, very different, but at the same time, they had to be kept aware of the evolving nature of the definition of our cohort and the data elements that were critical to understand what was being included in the care that the patients were receiving, whether we're using BiPAPs, we're using ventilators, things of that nature. We actually did some brand new things with BiPAPs and converting some technology to be able to increase the number of ventilators that were available during the height of the crisis. Then the other piece that was a little challenging is we needed to limit access to the COVID data marts because the definitions were changing rapidly, and the other piece was the governor was on TV giving statistics on a daily basis, and those tended to be several hours old. The information in our operations center was much more real time, so we needed to really make sure that we're balancing that and providing the public with the right level of information at the right time, and not getting ahead of the governor and the things that he was trying to achieve for purposes of public health. Then we really had to define a process to reprioritize and deviate data science team activities to create, validate, and iterate and deploy the machine learning predictive models. Again, everything was fluid during the whole process, so this was really important for us to continue to refocus our efforts and reevaluate where our priorities were. Then finally on this one, we had to design and deploy visualizations that support command center operations, our ambulatory network, PCR and serology testing, and PPE distribution. We learned a lot about serology testing in my team in a very short period of time, and it was very interesting because I don't think any of us had any understanding of how those workflows were done and what the significance were. But one of the amazing things that we experienced is because of our exceptional preparation, because of the executive leadership that we have in the organization, they planned for a long, long time for a number of very, very disruptive, catastrophic events that may impact and disrupt services of the health system. And the pandemic was one of those, and very fortunately for us, even though we learned a lot on the fly and we know things could be better and we're going to try to improve, we were very well positioned because of the exceptional leadership that we have in the health system. Now I'm going to show you a couple of examples where we're getting close to the end of my presentation here. This actually shows our currently admitted patients. And as you can see, there's a number of different characteristics that we're measuring here. So if you see on the upper left on this particular slide, it's admitted patients under investigation. So these are patients that we think have symptoms. They kind of seem like they might be COVID. And remember, early on, we didn't really have the ability to do testing in the first few weeks. So this was a significant number for us to watch. And if they were under investigation, they needed to be in isolation. We're showing the number of confirmed cases, the number of patients that are in our ICUs, the average length of stay, the number on ventilators, the demographic data around the patients, and as well as the comorbidities. And as you can see here, the comorbidities really reflect what you probably saw, if you recall, on the daily briefings that were going on at the state and national levels. This is an enterprise view that tells you all of the testing results across the organization, both from an inpatient and ambulatory perspective, as well as patients that have been tested through our core labs. This is at a high level. There's a number of different views that you can drill into to look at the demographics and the geographic locations of where the patients are originating from. As you may have heard, we had some hotspots in the Huntington area as well as parts of Queens. We were able to geocode this and monitor things on a daily basis to really understand what was happening, whether it was community spread or if there was something, an anomaly just in maybe the areas where the primary patient load that we were seeing was coming from. Maybe some of our employees who were impacted because of their direct contact with patient care and the COVID wards that we were standing up and supporting. And this is another great visualization that we had to put together on the fly to track our distribution of N95 masks. We got the call to help with this. They were distributing them on a daily basis, but they didn't have a great mechanism to track it. So we stood up a very quick data model and an interface that allowed them to track it as they were distributing it to each individual. As you can see, it's mapped by the different sites that the employees were reporting to and providing care. And it also gives a breakout of the service category and the job function for each of the employees. Then you also can look at the different sites and see the volume of PPE that was being distributed. And lastly, this is the serology testing grid that we put together. We got a call from the governor's office, and we were asked to start providing some serology testing for some municipalities, faith-based groups, and first responders, et cetera. So we put this together to really track the results as the tests were coming through. You can see the job function. This is a bit generic intentionally because we actually provided services to a number of different types of employers, and we're still doing this service today. As folks are asking us for it, and we're giving them as much granularity in terms of the demographics as they can provide to us to be able to understand what's the impact on their workforce and what kind of roles and what are the demographics and geographic types of impacts that may be reflected in what those employees might be experiencing. And with that, we'll come to the key learnings and recommendations. The first thing we talked about was dedicating a cross-functional team with clinical and technical resources. I think this is a really important thing to consider if you're not organized that way. You might want to put some things in place so that if you need to, you can make some adjustments on the fly to begin to really coordinate and collaborate to facilitate the things that need to be done as you're responding in a crisis of this nature. Again, flexible parameters, flexible model for identifying a cohort. You've got to iterate and communicate. This is really, really essential to make sure that everyone understands the evolving definitions of cohorts as you're navigating something like this when the definition is not stable. Establishing the regular meeting cadence, again, very, very important. Making sure that the communication is constant, it's clear, and there's no ambiguity around how things are defined to ensure that the right information is available for the right purposes and the right decisions. And then lastly, it's really, really valuable if you have an analytic resource center, center of excellence, or whatever your enterprise function might be that has the ability to see the different activities across the organization. It's a really important benefit to be able to understand what the needs are, what are the demands, and then identify which teams are best suited to tackle them and make sure that everyone understands what they're accountable to deliver and make sure that you're not having any redundancy or risk of defining things in a disparate way to be able to deliver for your organization. With that, I want to thank you for listening, and we'll pause for questions.